Hello everyone and welcome to our module on antidepressants. There are a lot of medications that are used to treat depression, and an easy way to keep them straight in your mind is to break them down into 5 groups, which we'll go through in this video. First are the tricyclics, then the MAO inhibitors, then the SSRIs, the SNRIs, and then finally some others which don't really fit into one of the other categories. Before we get into specific antidepressant drugs, let's talk about some general principles of depression. Depression is associated with decreased activity in the central nervous system of certain neurotransmitters, in particular serotonin, norepinephrine, and dopamine, and patients with depression can have improved symptoms if you boost the activity of these neurotransmitters in the central nervous system, and that's how most antidepressants work. They increase the levels and the activity of these 3 neurotransmitters. There are basically 2 ways by which most antidepressants do this. Either they block the reuptake of the neurotransmitter in the synapse. This leads to higher levels in synapses, or they inhibit the breakdown of the neurotransmitter so that higher levels will be present in the brain. So here's my own drawing of a synapse in the central nervous system, and we have a presynaptic neuron that is going to release a neurotransmitter into the synaptic cleft, which will then exert its effects on the postsynaptic neuron. The way that most neurotransmitters work is either by blocking the reuptake of the neurotransmitter or by inhibiting its breakdown. Either of these mechanisms will boost the levels of neurotransmitter in the synapse and increase the activity level of that neurotransmitter in the brain. Now let's go through the 5 different groups of antidepressants. We'll start with the tricyclic antidepressants. These drugs are called tricyclics because their chemical structures contain 3 rings. For example, at the bottom of the screen are the chemical structures of nortriptyline, imipramine, and amitriptyline. Those are all examples of tricyclic antidepressants. These are old antidepressants that came on the market in the 1970s, and they're rarely used to treat depression in the modern era. The way they work is by blocking the reuptake of serotonin, which is also called 5-hydroxytryptamine or 5-HT, and also the reuptake of norepinephrine. So by doing that, they boost the activity level of these 2 neurotransmitters in the brain. The problem with these drugs is that they have very broad spectrum effects on a number of receptors. They block the effects in the brain of histamine, they can block muscarinic receptors, and also alpha-1 receptors. And because of these effects here, they have many side effects, and that's why they're not used much in the modern era. For example, their antihistamine effects often lead to sedation and weight gain, and if you give these drugs to elderly patients, they often become confused. By blocking cholinergic or muscarinic receptors, patients can develop blurry vision, constipation. Dry mouth was a big problem. Patients used to take these drugs, used to be thirsty all the time, and in addition, they could develop urinary retention. And then through alpha-1 blockade, patients who took tricyclics would often have orthostatic hypotension. You can break tricyclic antidepressants down into 2 groups, the so-called tertiary amines and the secondary amines. The tertiary amines have a nitrogen with 3 attachments. If you look at the bottom of the screen, imipramine is a tertiary amine. This is the nitrogen group here, and it's got 1, 2, 3 attachments. Therefore, it's a tertiary amine. Drugs in this class include imipramine, but also some of these others I've written here, like amitriptyline, clomipramine, doxepin, and trimipramine. And the thing about these drugs that you need to know is that they tend to be more sedating. They tend to have more histamine effects. So years ago, when these were the most commonly used antidepressants, if a patient had trouble sleeping, their doctor would often prescribe a tertiary amine because it was sedating. The secondary amines have nitrogens with 2 attachments. So nortriptyline is a secondary amine, and it has a nitrogen here with only 2 attachments, not 3. So examples of secondary amine tricyclic antidepressants are desipramine, nortriptyline, and protriptyline. And these tended to be more activating. They had more norepinephrine effects. So you would give a secondary amine to someone who had trouble staying awake during the day and felt very fatigued. The problem with tricyclic antidepressants, in addition to the side effects, is that when they're used to treat depression, if patients become suicidal and overdose on these drugs, they're potentially fatal. All of the things I've listed on this slide can occur among patients in the setting of a tricyclic antidepressant overdose. First of all, patients can develop seizures and potentially coma. That's because at high dosages, tricyclics antagonize GABA receptors in the brain. These drugs also block cholinergic receptors, so they can cause anticholinergic toxicity. So when you block cholinergic receptors, you can't sweat. And when you can't sweat, you can't dissipate heat, so you get very hot. And so hyperthermia develops, and people with anticholinergic toxicity develop a fever. When your temperature starts to go up, your body dilates the skin, so these people have skin flushing. In addition, the pupils will dilate. That's because you're blocking cholinergic receptors. And then in the gut and in the bladder, you can develop ileus and urinary retention. These are all classic features of anticholinergic toxicity, and they can occur in patients who overdose on tricyclic antidepressants. And then finally, because of alpha receptor blockade, hypotension can develop, and this is a major cause of death. In addition, the QT interval on the EKG can prolong, and this can lead to arrhythmias. If you ever end up treating a patient with a tricyclic overdose, and I've had to do this once in my career, you will admit them to the ICU for close monitoring. What you want to monitor is the ECG for increased QRS interval. This is the most prominent manifestation of toxicity, and this occurs because tricyclic antidepressants at high dosages can block cardiac sodium channels. So when these patients are in the ICU, you put them on telemetry and you regularly check EKGs to make sure that their QRS interval is not becoming prolonged. The treatment for tricyclic overdose is infusion of sodium bicarbonate. This has two effects. The sodium in the infusion overcomes the tricyclic antidepressant sodium channel blockade in the heart, and this helps to reduce the chance of arrhythmias. In addition, sodium bicarbonate raises the pH because it's a base, and this favors the inactive form of the drug, so it will exert less effects on receptors in the body. Now, as I told you before, tricyclic antidepressants are rarely used in the modern era to treat depression, but they do have a number of non-depression uses that you may still see clinically. Clomipramine is a tricyclic antidepressant that is sometimes used to treat obsessive-compulsive disorder. There are two tricyclics, amitriptyline and desipramine, which can be used to treat diabetic peripheral neuropathy. Patients who have chronic pain syndrome sometimes see improvement of their functioning and overall pain level with a number of tricyclic antidepressants. All the ones I've listed here on the slide can potentially be used. Amitriptyline is sometimes used to prevent migraine headaches. Children who have bedwetting, which is called enuresis, are sometimes treated with tricyclic antidepressants because remember what I told you before, they cause urinary retention. They're not first-line therapy. The first-line therapy is desmopressin, which is an ADH analog, but if desmopressin doesn't work or the patient can't take it, there are a number of tricyclic antidepressants that are sometimes used. And then finally, as I told you before, some of these drugs are sedating, so they can be used for insomnia. The one that's usually used for this purpose is called doxepin. Moving on, let's talk about our second class of antidepressants, the monoamine oxidase inhibitors, or MAO inhibitors. As their name implies, these drugs inhibit the enzyme monoamine oxidase, and when this enzyme is inhibited, there is less breakdown of monoamines. So what are monoamines? Well, it turns out many neurotransmitters in the brain have a chemical structure called a monoamine, which includes a benzene ring attached to an amine group. Norepinephrine, dopamine, and serotonin, which is also called 5-HT, are all examples of monoamines. So when you inhibit monoamine oxidase, you get less breakdown of all three of these neurotransmitters and therefore higher levels in the brain of serotonin, norepinephrine, and dopamine. There are two subtypes of the MAO enzyme. MAO-A breaks down dopamine, serotonin, and norepinephrine, and MAO-B breaks down mostly just dopamine. Just like tricyclics, these drugs are rarely used in the modern era anymore because of side effects. But years ago, there were three MAO inhibitors that were used to treat depression. They were tranylcypromine, phenelzine, and isocarboxazid. These were non-selective MAO inhibitors that inhibited both MAO-A and MAO-B. Nowadays, there is a drug sometimes used to treat Parkinson's disease. It's a selective MAO-B inhibitor, so it only boosts the levels in the brain of dopamine, and that drug is called selegiline. So in the modern era, the only place you'll really see MAO inhibitors used are for refractory depression, sometimes for anxiety, and as I said before, selegiline is a selective MAO-B inhibitor used in Parkinson's. Years ago, when MAO inhibitors were used more routinely to treat depression, these drugs were a common cause of the serotonin syndrome. The serotonin syndrome is a clinical syndrome that occurs when patients have too much serotonin activity in the brain. And you can remember the clinical features by the three A's. So the first A is for agitation. That's because patients with serotonin syndrome have mental status changes. They're agitated, restless, and sometimes disoriented. The second A is for autonomic hyperactivity. These patients are sweaty, their heart is racing, and often their temperature is elevated. And then the last A is for neuromuscular hyperactivity. These patients have muscles that are going haywire, so they can have tremor, clonus, hyperreflexia, and if you perform the Babinski test, you'll often find a bilateral Babinski sign. The treatment for this syndrome is a drug called cyproheptadine. It's a serotonin antagonist. So like I said, years ago, when MAO inhibitors were more commonly used as antidepressants, they would sometimes lead to the serotonin syndrome. And the way this would happen is that a patient who is on a MAO inhibitor for depression would then take some other serotonin-boosting drug, and that would lead to the serotonin syndrome. So what are some of the drugs or substances that, when taken together with MAO inhibitors, can lead to the serotonin syndrome? Let's talk about that now. These are all high yield for you to know for step one. So if a patient on a MAO inhibitor took another type of antidepressant like an SSRI or an SNRI, which we'll talk about later, or a tricyclic antidepressant, this could boost serotonin levels to the point that the serotonin syndrome would develop. Patients who abuse ecstasy, which is also called MDMA, this is a drug of abuse, this boosts serotonin levels, and that can lead to the serotonin syndrome in someone on a MAO inhibitor. Ondansetron is an antiemetic. It's used for nausea. It's a 5-HT3 antagonist, meaning that it blocks the subtype 5-HT3 receptor for serotonin. So why does this lead to the serotonin syndrome? Well, when you block this receptor subtype, that leads to more activity at the 5-HT1 and HT2 subtypes of serotonin receptors, and that can potentially cause the serotonin syndrome. Tramadol is a weak opioid, but it also inhibits serotonin reuptake, so that can lead to the serotonin syndrome. Meperidine is also an opioid that inhibits serotonin reuptake. Triptans are drugs used for migraine headaches. They are serotonin agonists. Linezolid is an antibiotic that I talk about in the infectious disease section, and it has weak MAO inhibitory activity. So if taken together with a MAO inhibitor, this could lead to the serotonin syndrome. Dextromethorphan is a cough suppressant, but it also works as a weak SSRI. And then finally, St. John's wort is an herbal supplement that some people take for depression. And the way that it works is by increasing serotonin activity, and therefore that can lead to the serotonin syndrome. So because of the possibility of interaction between all of these substances and MAO inhibitors, there's usually a 2-week washout if you want to stop a MAO inhibitor and start some other drug that has serotonin boosting activity. So for example, when switching someone from a MAO inhibitor to an SSRI, you would stop the MAO inhibitor for 2 weeks, and then you could start the SSRI. So the serotonin syndrome was one reason that people stopped using MAO inhibitors once other antidepressants came available. The other reason was because of something known as the cheese effect. So let's talk about that now. Tyramine is a naturally occurring substance that is a monoamine. This is its structure on the screen here. It's got a benzene ring attached to a nitrogen group. If it gets into your bloodstream, it can act as a sympathomimetic and activate sympathetic nervous system receptors. Now, normally it's metabolized in the GI tract, so it doesn't get into your bloodstream, but it's metabolized by monoamine oxidase. So in patients who are taking MAO inhibitors for depression, if they eat foods that contain tyramine, tyramine could get into the blood, and this could cause a hypertensive crisis. These patients would develop headache or chest pain and have markedly elevated blood pressure. And this was called the cheese effect because there's lots of tyramine in cheese. There's also tyramine in red wine and some meats. So the classic scenario that you may still see in your board exams is a patient on a MAO inhibitor who goes out to dinner and has pizza and red wine and then comes in with hypertensive urgency. That patient is suffering from the cheese effect, and the cause is tyramine that was present in the food. Now let's talk about the next class of antidepressants, the selective serotonin reuptake inhibitors, or the SSRIs. As the name implies, these drugs inhibit the reuptake of serotonin by neurons, and this leads to increased serotonin levels in the synaptic cleft. These drugs have a slow onset of action, so when patients are depressed and you start them on an SSRI, you need to let them know that they're not going to notice the benefit the first day. It usually takes about 4 to 8 weeks to see effects. And there are a number of different SSRIs. I've listed all their names here in this box. And you should be aware that in addition to depression, they're also used in many other psychiatric disorders. They have some effect in generalized anxiety disorder, panic disorder, obsessive compulsive disorder, bulimia, social anxiety disorder, and PTSD. The main side effect of this drug that's a problem for patients is sexual dysfunction. This is believed to occur because of increased serotonin effects in the spinal cord. About half of patients will have a decreased libido, which means a loss of interest in sexual activity. And this can be a big problem if you're treating depression in a person who's married or a person in a long-term relationship. Another side effect is anorgasmia. People on these drugs have great difficulty achieving orgasm in a lot of cases, and this can be very frustrating. In addition, men often have erectile dysfunction when taking an SSRI. Other side effects are shown on this slide. Some patients develop GI upset because of GI serotonin effects. These are things like nausea, abdominal pain, and constipation. Some patients are drowsy on these drugs, and some patients gain weight. And then very rarely, there have been reports of serious side effects like SIADH or hyponatremia or QT prolongation, but this is relatively uncommon. Moving on, the next class of drugs are the serotonin norepinephrine reuptake inhibitors, or the SNRIs. And as their name implies, they inhibit the reuptake of both serotonin and norepinephrine, so they have effects on both neurotransmitters. These drugs also have a slow onset of action, just like the SSRIs, and they're used in many psychiatric disorders, also just like the SSRIs, not just depression, but also generalized anxiety disorder, social anxiety disorder, panic disorder, PTSD, and OCD. These are all things where SSRIs also have a role. In addition, one SNRI has shown some effectiveness in fibromyalgia, that's duloxetine, and venlafaxine has been shown to have some effect in diabetic neuropathy. And I've listed the names of the SNRIs in this box here on the screen. Because these drugs have norepinephrine effects, they can raise the blood pressure, and it's very high yield to remember that for board exams. A patient started on an SNRI who comes into clinic a few weeks later with hypertension may be having an adverse effect of the drug. Just like with the SSRIs, some patients on these drugs have nausea, although this usually gets better with time. And also, just like the SSRIs, some patients experience sexual dysfunction. The highest rate is seen with the SNRI venlafaxine. For the rest of this video, I'm going to talk about other antidepressants that don't really fit into one of the categories we've talked about up to this point. And the first drug I'll talk about is bupropion, which goes by the trade name Wellbutrin. This drug blocks the reuptake of norepinephrine and dopamine. It also increases the release of catecholamines, and it has no effects on serotonin. This is used in depression, and it's also used in smoking cessation. I talk about this in the video on stimulants, but there are data that smokers who take bupropion when they're trying to quit are more likely to quit. The thing you want to remember about this drug is that it's relatively activating, and it has the opposite effects of the SSRIs in many cases. So this drug can improve sexual dysfunction, and so it's often given together with an SSRI to cancel out the sexual dysfunction caused by the SSRI. It's also somewhat activating, so it sometimes cancels out the sedation that some patients develop on SSRIs. So a very popular combination to treat depression is an SSRI plus bupropion. The toxicity is related to the fact that it works on catecholamines and norepinephrine, so it has stimulant effects. So some patients on this drug can have anxiety, some patients have insomnia, and rarely, especially with older formulations of this drug, it's been reported to cause seizures. Our next drug is mirtazapine, which goes by the trade name Remeron. This drug blocks presynaptic alpha-2 receptors, and that leads to more norepinephrine and serotonin release. I'll show you a picture of how this works in a minute. In addition, in the postsynaptic neuron, this drug blocks two subtypes of the serotonin receptor, the 5-HT2 and 5-HT3 subtype. Because it blocks these two receptors, serotonin exerts more effect on the 5-HT1 subtype of receptors, and this is related to some of its beneficial effects. The thing you want to always remember about mirtazapine is that it has lots of antihistamine effects, and this is what causes its side effects. It's very sedating. It's often given to patients with depression who have trouble sleeping at night. They can take it right before bed. It also can cause a dry mouth, increased appetite, and weight gain. These are all antihistamine effects. Here's my own drawing about how the alpha-2 receptor blocking effects of mirtazapine work. So when a presynaptic neuron releases norepinephrine into the synapse, negative feedback is provided by norepinephrine acting on alpha-2 receptors. This tells the presynaptic neuron to stop releasing neurotransmitters. If you block this alpha-2 receptor with mirtazapine, then the negative feedback is blocked, and therefore more norepinephrine and serotonin are released into the synaptic cleft. The last three drugs I'm going to talk about in this module are among a class of drugs called serotonin modulators. These drugs inhibit the reuptake of serotonin just like SSRIs, but they also have properties as antagonists or agonists of some types of serotonin receptors. They have minimal effects on norepinephrine or dopamine. And the three drugs that are considered serotonin modulators are trazodone, vilazodone, and vortioxetine. Trazodone is a weak serotonin reuptake inhibitor, so in this way it functions like an SSRI, but it also has effects on two subtypes of serotonin receptors, the 5-HT2A and 5-HT2C receptors. At low dosages, it's a blocker of these receptors, but at high dosages, it's an agonist, and that's why it can be used as an antidepressant. Now, in the modern era, it's no longer used as an antidepressant because of side effects and because of better drugs that are available. Its main clinical use in the modern era is for insomnia. This drug is very sedating. It has strong antihistamine properties, so the one place you'll commonly see this used in the modern era is as a sleeping pill. Vilazodone blocks the reuptake of serotonin, much like SSRIs. It's also a partial agonist to a subtype of serotonin receptors called the 5-HT1A receptor. The main side effects of this drug are similar to side effects of SSRI. It can cause diarrhea in about a third of patients. It can cause sexual dysfunction, and there are case reports of patients taking vilazodone who develop the serotonin syndrome. Our last drug is vortioxetine. This blocks the reuptake of serotonin. It also has multiple properties on serotonin receptors. It's an antagonist of some subtypes of serotonin receptors and a partial or full agonist of other subtypes of serotonin receptors. It's unlikely they'll ask you about these specifics on your boards. The thing to remember is that this drug works on serotonin receptors. And the main side effect is nausea. Just like most serotonin drugs, it can cause GI upset. And that concludes our video on antidepressants.